what I thought I'd share is I put together some reflections on working together as a multidisciplinary team towards the management of spinal disorders. And right now, I just wonder, in terms of who's here today, how many in the audience are primarily surgeons, either orthopedic surgeons, neurosurgeons, or spine surgeons? And then how many are non-operative specialists? So how many might focus more on non-operative things and management? Well, terrific, and it's good to have the balance here. And what I want to talk about is how can we really improve quality of care, and really focusing on in a reforming healthcare economy. So an economy that's changing, where we've got MIPS and MAPS programs, where we've got bundle payments. How can we actually incentivize optimal care or appropriate care? Because I think sometimes in a fee-for-service type of economy, or when we have a really myopic or monolithic approach, then sometimes I think what we're doing can be somewhat inefficient. These are my disclosures here, and importantly, I don't plan on speaking to anything with regard to any industry topics here. This is going to be much more based on optimal care and value-based care. So what I want to go through is I'm going to start off just briefly setting a stage with why spinal disorders are such an important part of our healthcare economy, why they're a priority, and I'm going to define basically the burden of disease with that. And then what I want to focus on a bit is the idea of measuring quality and measuring value of spine care. And I'm going to talk a bit about then our experience at UCSF with regard to expenditures and some of the variability that we've observed in the cost of both single-level care. That's actually an article that I hope Jens is going to publish, because I think it's on his review team right now at the Global Spine Journal. And then focus a little more on multi-level surgery and deformity surgery, where the variability is that much higher. We'll transition then a bit into what we get for those costs, and then obviously some work that you've all contributed to here, Rod and Jens and others in the room, with regard to predictive modeling, and a terrific article you had in JAMA recently on predicting not only complications, which has been a big part of our work, but predicting outcomes. Let me go backwards again. And then finally, I'm going to talk about what our experience has been with regard to creating really a value-based spine care service, creating a service that's integrated, and working with our non-operative team as well as our operative team to try and create a service that works in a healthcare economy that's value-based and that really is focused on appropriate care rather than inappropriate care. So to that end, what I want to start with is this notion that the spectrum of things that we see as physicians, so not just surgeons, but as physicians who deal with disorders of the spine, we see all sorts of things that run from deformity to tumor to trauma to degenerative pathology. And ultimately, what this adds up to is a broad spectrum of conditions. And when we think about how important are spinal conditions in our healthcare economy, well, this is some work that we had done out of the burden of musculoskeletal diseases. Maybe some of you have seen this. This is a publication out of the burden of bone and joint diseases. But fundamentally, the notion here is that our healthcare priorities for our healthcare economy ought to be defined by the burden of disease. And so that's defined as a prevalence, is how prevalent are disorders, and also the impact of the disorders on individual patients. So in terms of prevalence, from some of our work that was published in this U.S. Bone and Joint Decade publication, we know that patients with joint pain, neck pain, back pain, radicular pain, that this is among the most prevalent conditions known, more so than heart disease or stroke or even upper respiratory infections. The prevalence of musculoskeletal problems is high. And to that end, if we look at low back pain, neck pain, radicular pain, this is a major problem in terms of prevalence and a high prevalence in our economy. Looking at the expense of this is also important. In the medical expenditures, musculoskeletal care overall, close to $200 billion a year, and incrementally, spinal disorders are a major part of that and a rising part of what we're spending on healthcare. Now, so prevalence, expense-wise, big part of our healthcare economy. Well, what about the impact of spinal disorders? And all of you are familiar here. This work coming from Murray and the group here in Seattle, published in Lancet, looking at the global burden of disease. And essentially what we know here is looking at 220 different disease conditions, global disability or disability-adjusted life years, patients with spinal disorders, there's a major impact of basically low back pain and spinal disorders. Getting a little more granular about that, some of the work that we did in looking at the impact or the burden of spinal disorders on our economy, we published this in Core now almost 10 years ago. And this is some work that actually Indra Conti at that time was a medical student. Now she's doing family practice in Texas, but she worked with me on this. And essentially what we did is we took many common conditions and looked at the utility of these different conditions, so the patient's health status preference for everything from rheumatoid arthritis to anxiety disorders to COPD, peripheral vascular disease. We found that the patients that we were seeing for spinal disorders routinely self-assess their health status as being more impacted by their disorder, or self-assessed their quality of life as being lower than any of these common medical conditions. So this was an early effort to try and quantify the impact of spinal disorders on patients. And then more recently, I think some of the work coming out of the European Spine Study Group, the International Spine Study Group, this was a particularly good one, looking at nearly 25,000 patients across Europe and SF-36 scores. And essentially what this showed is that the subset of patients with deformity of the spine actually had measurable decrements of health quality in every domain. So physical function, bodily pain, role physical, general health. So patients with spinal disorders are majorly impaired. And the conclusion here, especially as patients with deformity, there's a significant and measurable impact on health status, and in fact, much more of an impact than many common medical conditions. So the conclusion then becomes, well, gosh, in terms of a burden of disease, and if a burden of disease, if the NIH suggested, or if we suggested our healthcare priorities ought to be defined by the burden of disease, so both the prevalence of disease as well as the impact, well then, golly, we ought to, spinal disorders ought to be way up there. Having said that, disproportionately, they're really underrepresented in a lot of areas, including funding for research. And this is some work that was done out of my colleagues here at UCSF, trying to define, well, where does money get allocated in terms of research, and to what extent does the burden of disease define allocation? And to a large extent, spinal disorders are really underfunded. Yet having said that, what we do is important and ought to be a priority. It ought to be a priority, but the way we're doing it right now is probably unsustainable. And what are the real deficiencies in how we're providing spine care right now? Well, fundamentally, unsustainable costs. I'll talk a bit about the rate of rise of cost, but also terrific variability. And to some extent, what you get depends upon who you see, and whether you see a physical therapist, or whether you see a physiatrist, or whether you see a pain management specialist, or whether you see an orthopedic surgeon, or whether you see a neurosurgeon. Across the spectrum, tremendous variability in what you get depending on who you see, and to a large extent, quality deficiencies. And ultimately, if we're going to be accountable for quality and for outcome, then we've got to be appropriate in how we use our resources and how we care for patients with common disorders. If we look at medical expenditures, so talking about unsustainability to start off with, a terrific rate of rise of medical expenditures, and when we specifically think about spine fusion procedures, almost $300 billion, $80,000 per case over the first decade of this century. And within the Medicare population, complex surgeries are rising the most rapid. And we published recently in the Journal of Neurosurgery an article suggesting that in a subset of patients who are over age 70, the most rapid rate of rise is in multi-level fusions. And I'll show you some data from that. And the cost burden on this is really unsustainable. It's really approaching some more chronic medical conditions, including diabetes and cardiovascular disease. This is an article that was from 2012, and it was out of the group at Cedars. Rick Delamarter was the lead author here. And what I think it exemplifies pretty nicely is the notion of a geometric rate of rise. So both there's an arithmetic rate of rise in terms of the amount of surgery that's being done, And this is especially in a Medicare population, but also the rate of cost per surgery. So the invasiveness or the intensity of the surgery is also rising arithmetically. So when you take that together, an increase in cost per case as well as an increase in the number of cases, this gives us a geometric rate of rise in what we're spending on spinal disorders. And this is what we're seeing in medical care in general. We're seeing a geometric rate of rise in what we're spending, and spinal disorders just being a microcosm of that. In the U.S., we're spending about $8,800 per patient right now, compared to other healthcare economies where, the second largest, Switzerland, is in a range of about $5,800. Interestingly, the subset of patients who have a DRG for any spinal disorders is about $3,000 more. So for every patient who has who's being seen with a diagnosis of a spinal disorder, the incremental cost is about $3,000 more. And where that becomes relevant is if we're going to try and look at accountable care for a population of patients, if we're going to manage the spine portion of that, about $3,000 per patient is the incremental cost for an entire population. So we're spending a lot of money on this, again, about $88 per patient. And what are we getting out of this? Well, by a lot of measures, including life expectancy, we're not necessarily doing better than other industrialized countries. So although we spend a lot more, we're not necessarily getting better outcomes. And to some extent, Kurt Vonnegut said, in this world, you get what you pay for. But the Dodgers and others, I'm not sure how it'll end up this year, but others suggest that you don't necessarily get what you pay for. So, and this is true broadly, looking at healthcare and correlating spending as an outcome. And a lot of work has suggested, in fact, Jack Wenberg and Fisher and others have suggested that, in fact, in areas that spend more money, you're less likely to actually get evidence-based care. And in some serious conditions over time, survival and appropriate care is actually less in regions that spend more. So to some extent, there's an inverse correlation between what we spend and outcomes. And I'll show you some of that data from UCSF and spine. So bringing this back from general medicine to managing spinal disorders, I think the way we manage spinal disorders is characterized by a terrific amount of variability. And whether you're from where I trained in Boston versus up here in Seattle or San Francisco, or many of our multi-center studies, we've got centers from Japan, from India, from Western Europe, from around the world. A terrific amount of variability in our treatment strategies and in our plans. And again, it gets to the notion of what you see depends upon, or what you get depends upon who you see. The Dartmouth group has done a nice job of looking at variability, and fundamentally, I think what we see here is and this is work that John Knightley looked at with the N2QOD. And one of the real priorities of the N2QOD is the notion that there's a lot of unexplained variation, and unexplained clinical variation's got to be resolved, and that's where we've got to work better on an evidence-based approach to care. And John, who's a military man who talks a lot about military analogies, he says, well, variability is actually the enemy of equality. So how do we address that? Just some more information on variability, looking at rates of surgery again, where we are up here in the Pacific Northwest, rates. My pointer or my geographic skills, something's off here. Rates of surgery much higher than they are where I trained, say over here in Boston. You might say, well, that makes sense. Out here in the Pacific Northwest, we've got all these lumberjacks and all these people out working hard, and in Boston, everybody's in the library all the time. So there ought to be more spine surgery. But in fact, that's probably not the reason. It's probably not patient demographics. And Jack Wenberg and others looked at small area regional variation, even among demographically very similar populations. Rates of surgery defined by factors other than patient-dependent factors. And I'm going to get to those factors in just a minute. But just to show you, we're not alone in spine surgery. The hip arthroplasty, the hip shoulder arthroplasty, many elective musculoskeletal procedures are also characterized by a lot of variability. So what's the basis of this variability? This is Jack Wenberg with Jim Weinstein up here in the White Mountains in New Hampshire. And fundamentally, it's this notion of a surgical signature. So rather than having a rate of surgery that's based upon a prevalence of disease or by patient choice, a lot of times it has to do with the so-called surgical signatures, individual practice patterns, regional practice patterns, the notion of apprenticeship learning, I do it this way because this is how I learned to do this, and a perpetuation of established practices that aren't necessarily evidence-based. And fundamentally, this is perpetuated by an incomplete and inefficient exchange of information. And that's why I think to some extent us working together here and talking together here gives us the ability to exchange information and create a consensus between our practices. I also want to point out, though, I really don't want to be dogmatic about the notion of, well, we've got to do it the same way every single time, because I think there are some really positive aspects of variability. And I wrote about this in Spine recently, and Sean Tunis wrote about this in the New England Journal. But the idea that to some extent variability reflects patient preferences, so not every patient is the same. So the idea of trying to have a CPG type of a guided approach to care doesn't really necessarily respect patient preference, patient values, and some patient-specific factors, as well as to some extent surgeon preference. And ultimately, if we're going to talk about precision medicine and personalized medicine, I think we need to recognize those patient values and patient preferences as well. So to some extent, we really don't want to create a healthcare system that is monolithic. So where's healthcare reform come into this? And many of us think that, well, healthcare reform really died with the election of the new administration. But indeed, I think many of these principles are still relevant and need to be addressed. Healthcare reform was really brought on to address, again, the unsustainable rise in cost of care, to reduce variability, especially variability in access to care, and fundamentally to try and incentivize value over volume. So that's where a lot of the principles of healthcare reform were introduced, and these principles are being maintained even within our current administration. Fundamentally, this notion of moving away from volume towards value is continuing in our healthcare system, although a little bit more quiescently now. So this notion of incentivizing quality, incentivizing value of care really requires us to choose appropriate dashboards and fundamentally to set expectations for what are our expected outcomes, and in comparing our observed outcomes to expected outcomes. And that ratio of expected versus observed is ultimately what's going to define quality. And the important part of this is this notion of risk adjusting, is recognizing that all patients aren't the same. And as you know from your predictive modeling work published in JAMA, that there's a lot of patient factors that go into what's the most important predictors of outcome. So making sure we adjust appropriately for the invasiveness of surgical procedures, but also for patient-dependent factors. So again, measuring quality is difficult, and we need to choose the right metrics. And we wrote about this about a decade ago now, looking at, again, the Institute of Medicine identified specific deficiencies in quality of care, and the notion of how can we create financial incentives to actually incentivize appropriate care rather than just a large volume of care. And what we looked at in terms of quality metrics is we found that, well, there are a lot of process variables that are really easy to measure. So we can measure whether or not the patient got antibiotics on time, whether or not we used DVT prophylaxis, whether or not the electronic medical record was used. And we can also document, to some extent, rates of surgery, rates of variability, how much MRI scan are we using, what percentage of our patients, new patients that are seeing, go on to surgery. Now, those variables alone are easy to measure, and similarly, complications, return to the OR, reoperations, readmissions, all those things are easy to measure. But what I'll suggest to you is that when we focus just on these metrics, we really miss the broader picture of what quality ought to be. And I'll demonstrate that, I think, with this example. This is a 68-year-old woman who is from up in the northern counties of California. And she's actually a nurse manager. She's 68 years old and had been disabled and presented with symptomatic stenosis, a moderate spinal deformity. And a surgeon, very well intentionally, very well meaningly, said, well, golly, with your COPD and at your age and with your osteopenia, I really think we'll decompress the lumbar spine. And I recognize there's some deformity there, so I'll kind of tether the apex. And looking at this, as you'd imagine, correlating radiographic parameters with health status, this patient really had no improvement at all of her health status, and she remained disabled. Now, if we measure this by length of stay, well, single-level fusion, average length of stay at UCSF is 1.2 days. Readmission within 90 days for a single-level fusion, or readmission within 90 days is less than 2%. The cost is limited. There's no ICU stay. Very few complications. So if those are our metrics for quality, this is a perfect operation. And if we're dissociated from what the patient's assessment of her health status, then looking at an administrative data set, this becomes perfect. But we look at the fact that this patient had an operation and had absolutely no improvement in her health status, well, that's clearly problematic. And this is where we got to, what I ended up doing is a revision surgery and basically realigned her in both planes with an asymmetric PSO. Now suddenly revision surgery, multi-level, more than 5-level fusion. So our readmission rate at 90 days is 9% for this operation. Our infection rate for a revision surgery, multi-level, our infection rate is 4.2%. Our use of the ICU, so 15% of these patients end up spending at least 1 day in the ICU. Average length of stay is now 5.4 days. So suddenly you take something that was perfect on an administrative database and turn this into an expensive operation that by every metric of quality is a worse operation until you actually look at the patient's experience, look at her ODI score, look at her self-assessment, look at her utility scores and see a dramatic improvement of her health status. And that's what we've got to focus on and not just the quality metrics. So some of these dashboards, length of stay, readmission, different complications, a lot of times these really inaccurately or inadequately describe the patient's experience. We wrote about this in several articles about readmission rates and some of the pitfalls of looking at administrative data and the inaccuracy of dissociating the patient's experience and just focusing on administrative experience. So it gets back to the notion of what should we measure? Well, patient-centered outcomes is what we ought to be measuring. And this is not a new concept. Ernest Codman at the turn of the century back in Boston, he suggested it's our responsibility as healthcare providers to provide evidence for value, to look at the end result of care is what he described. And the end result of care he defined as a simple notion that the hospital staff should follow patients long enough to learn the end results of care. And we should learn from our misadventures. And then where he got in trouble is he said we should make these results public. And many of you know the story of Ernest Codman, and fundamentally he was at the Mass General Hospital. He did a lot of work in shoulder surgery, but also general surgery as well. And when he suggested making results public, this resulted in him actually leaving the status quo of the medical community there. He tried to start his own hospital, and World War I came about, and that went bankrupt, and he ended up actually being buried in a pauper's grave. But having said that, I think we're ready for this now, and this end result of care, not focusing so much on process measures or quality dashboards, but really focusing on patient-based outcomes, and that really being fundamental to what we're accountable for. Patient-based outcomes and patient-based outcomes are the numerator for our value equation. So to that end, going back to Porter and Teesberg's work on value, is the proposition here is that we want to take an analysis of the benefits of care relative to the risk, relative to the cost, and that's fundamentally what we want to optimize. So we want to optimize patient-centered outcomes and the cost to achieve those outcomes and the risk to those outcomes. And fundamentally, appropriate care is going to be optimizing those outcomes for the appropriate risk. And this becomes our challenge then. How do we improve outcomes? How do we improve quality measured in a patient-centered way and decrease the risk and cost of care? So what I suggest here is that optimal care is patient-centered care, and that we need information to make informed choices. We need information about the natural history of different disorders. We need information about what's going to happen with optimal non-operative care, and where does optimal operative care fit into this. And really understanding that there's a lot of heterogeneity. This heterogeneity is based on patient-specific factors, it's based on radiographic factors, it's based on surgical plans, and to some extent based on the patient expectations and patient goals, and recognizing that patients' values come into that, and that's why there's always going to be some degree of variability. We've done a lot of work in trying to reduce variability, and the idea of having a clinical practice guideline, and NAS has done some good work on this, is what should we do for spinal stenosis, what should we do for degenerative spondylolisthesis. Well, I think there are some good guidelines that apply broadly to populations, but to some extent, especially in the deformity world, I think we need to use appropriate use criteria. And the difference here is that with appropriate use criteria, we're really not focusing on the broad spectrum of a CPG or of a diagnosis broadly, but we're really trying to narrow in onto specific scenarios. And essentially, the appropriate use of care is that what's the expected health benefit And care is appropriate. So when does surgery make sense? Well, surgery makes sense when the expected benefit exceeds the negative consequences. The negative consequences include cost, but they also include risk. And fundamentally, when we exceed those consequences, that's appropriate. It's inappropriate when the expected harms outweigh the benefits. And that's pretty straightforward. And this was quantified in an article in JAMA back in 2001. And this is the RAND UCLA criteria. So, the RAND Corporation developed back in around the time of World War II for trying to make informed decisions under conditions of uncertainty. And the notion that on this 1 to 9 scale, the most appropriate interventions are those that where the expected benefit compared to the risk and the downside is high, and the simple notion that it's inappropriate if the risk exceeds the benefit. So using this criteria, we've written a couple of papers. We did one with the AO group looking at an international consensus for goals of surgery, for preoperative evaluation, for intraoperative strategies, and for postoperative care. And essentially what we showed here was where there was a consensus that's appropriate preoperatively to try and optimize patients, intraoperatively to use certain strategies, including osteotomies, and then finally postoperatively, early mobilization, DVT prophylaxis. We defined where there was consensus on pathways. And then another paper we were involved with here, this was an SRS sponsored paper, but with the RAND criteria. What we found is some of the real drivers of appropriateness for surgery and deformity included severity of preoperative symptoms, as you'd imagine, and as you well know from your predictive models published in JAMA, that one of the major predictors of postoperative or of the ability to improve is the severity of preoperative symptoms. Progression of deformity was a big one. Sagittal alignment, of course, being an important one with regard to defining what type of procedure. And importantly, the comorbidities and patient factors. So some of the risks that are the opposite side of our balance of our appropriateness equation. So understanding what are the risks for the individual patient and what are the patient factors that actually define risk. So, and this is what comes into the notion of being interdisciplinary, of trying to integrate care for optimal care. And certainly most of this from, as we've already defined, is spine surgeons. But what about our non-operative partners, our physiatrists, our pain management partners, physical therapists, and the multiple disciplines that come into evaluating the patients with spinal disorders, recognizing that one of the major things after upper respiratory troubles that primary care physicians see is spinal disorders, our ER staff. And how do we really put this team together into an integrated or an optimal approach to surgery? And how do we avoid the notion that what you get depends upon who you see? And most of you here in Seattle probably know about this work, right? So Dan Brown writing about the 1936 University of Washington boat. The first time I was ever in Seattle was to race on the, what's the cut here called? The Montlake Cut? It was so long ago where you kind of race and you have 6 lanes that narrow down. Anybody rode in that little area there? It narrows down into kind of 3 lanes, and it's pretty treacherous racing up here. But the 1936 University of Washington boat, who went on to win the Olympics. One of the major themes of this story is the notion that putting together a team, it can't always be the biggest and the strongest and the most outgoing or the most aggressive people. Like a team is an optimal team really requires a mixture of skill sets. And that's where putting together a multidisciplinary team, I think, is critical for, in this case, for winning a gold medal, in the case of spine surgery, for providing optimal care. And again, we already talked about the parties involved. So if we take an example here of a woman, this is actually a 36-year-old woman with a adult idiopathic scoliosis. So she had scoliosis for which she was really never braced as a child, and ended up with a pretty large curve here as an adult. So she's 36 years old. She actually works in a lab at UCSF, and her pain is actually pretty focal. She's got pain from this fractional curve here. So she's got left-sided pain at L4-5 and 5-1, some foraminal narrowing there. And she got pretty good relief, for 3-4 months with a series of injections, but she's reached a point where this has gotten worse. And how do we approach this? And she saw surgeons from actually around the country, and the range of approaches from, well, you needed surgery from T3 to S1 to something more limited. What I ended up doing in her case was just kind of fusing that fractional curve here. So it's fusing from L4 to S1, taking care of that radiculopathy and getting her in a bit of better alignment. And she still actually works as one of the chief lab technicians at UCSF. Now, the difference between that and doing something like this for a very similar deformity, well, it has a lot to do with the presentation of symptoms, but there's a big difference in cost. There's a big difference in mobility after surgery. There's a big difference in risks of surgery. And when to know which to perform is awfully important. And to that end, what is a cost-effective strategy? What is an appropriate strategy? Well, in many instances, non-operative care is the appropriate strategy. RIMS is, I don't know if that's a term. It's a term that I'm trying to popularize with Jerome Schroferman and some of the non-operative team at NASS. RIMS, is that familiar here? This rehabilitation, injections, medications. So basically, it doesn't make sense to me to define a field as non-operative. So the absence of surgery shouldn't really define a specialty. So this is something that Jerome Schroferman is popularizing, is the notion of RIMS being a non-operative care, not neuromodulation, pain management. So interventions that can really work for a lot of these patients. And I think David can speak a lot to this notion of how effective behavioral therapy, cognitive-based therapies can be, building that into a strategy. And then looking at other strategies, what's the role of circumferential fusion? How many levels do we need to do circumferentially? What's the role of different biologics, minimally invasive approaches versus open approaches? So this weekend, the ESMIS meeting is taking place, the Society for Minimally Invasive Spine Surgery. And while I've got a lot to learn from that cohort, I also think that there's a lot of unrealistic expectations for what we can do with deformity using percutaneous approaches. But trying to be cost-effective and trying to create optimal strategies to both minimize complications as well as improve the durability of outcomes, that's what really fundamentally gives us a value-based care system. What is cost ineffective? Well, having complications, having readmissions, having reoperations is cost ineffective when we see no or limited improvement of health status, or when the improvement doesn't last. And we've done some research on this suggesting that if we're going to do a big deformity surgery where the direct costs can be upwards of $100,000, well, if that's not lasting reliably for more than 5 years, and if we're not getting at least 0.3 or 0.4 utility points or quality years per year of life improvement, then that's not going to be cost effective. So this is where nonsense comes into our healthcare economy, or how we manage spine patients. So oftentimes when we're reimbursed based on value over volume, there becomes a dissociation between how we're reimbursed and the outcome of care. And this is what Paul Haggard had described as the moral hazard. The moral hazard being that when there's a dissociation between the reward that we get compared to the risk that we receive, then oftentimes that can create some tremendous disincentives. And Atul Gawande was with me both as an undergraduate at Stanford. We were dorm mates together at Stanford, and we started at med school in Harvard together. And Atul actually took off to join Clinton's healthcare cabinet after our second year of med school, and he's done a lot of work in exactly this, in a notion of perverse incentives for inappropriate care. So where's reimbursement reform come into this? Is where, if I suggest to you that our current fee-for-service economy has led to some unsustainable increase in care, and to some extent has driven inappropriate care, how does reimbursement reform perhaps lead to either some utopia or some optimal solution? And this reminds me of the road up to the Cascades here, or does reimbursement reform actually lead us towards driving towards a typhoon? And probably the answer is somewhere in the middle. So reimbursement reform, quality payments programs, you all know about the MIPS and MAPS program, the notion of merit incentives. This was repealing the sustainable growth formula. So sustainable growth formula, many of you know, every year Congress had to, up until 2016, every year Congress had to approve a healthcare budget And fundamentally, the notion was to try and shift the cost curve, so try and reduce the actual amount of the healthcare budget. And of course, every year this was overridden by Congress because the amount of increase in healthcare costs wasn't providing appropriately. So this was repealed for a merit-based type program. And the notion here is to try and focus with payment reform to try and focus on a continuum of care. So rather than just a single episode of care, where so much of what we focus on in terms of our economics is what happens right here in the hospital. We'll focus on how can we actually look at outpatient wellness, how can we look at preventative health, how can we minimize the use of emergency room visits, how can we limit readmissions, how can we, one of the things we've done is limit our readmissions to SNFs. We found out in our bundled payments work that actually the biggest variable that we can impact in a 90-day episode of care is what happens after the patient leaves the hospital. So looking at this entire continuum rather than just focusing on what happens here in the hospital. I had Michael Porter come to NASS, and he did a symposium with me about 3 years ago. I don't know if some of you might have been there, but Michael Porter suggested how can we pay for healthcare in the future is how can we fix an unsustainable healthcare economy? And what he suggested is that right now we're working in a fee-for-service healthcare world, and that there are really two major pathways. One of them is to work towards bundled payments, so to pay for an episode of care and to be accountable for that over 90 days. And another is looking at accountable care organizations, is looking at a population of patients and suggesting, well, to take care of this population of patients, the average cost is going to be about $8,000. So I'll take care of the spinal disorders in this population for a fixed cost or for a capitated cost. And I can assure you that under that system, we're not going to be doing a whole lot of T3 to S1 fusions. That won't be our first line of care in an ACO. So these are somewhat alternative pathways, but actually pathways that we're actually pursuing actively right now at UCSF, working with the Northern California Business Alliance with some ACOs, and I'll share with you some of our experience with bundles. Are you all enrolling in the new bundled, the new bundle somewhat? Yeah, so I'll share with you our experience for the pluses and minuses of that. This notion of bundled payments is fundamentally here to enter an arrangement where you're accountable for the episode of care, and the episode of care is defined by everything that happens within 90 days. So again, we're transitioning from a fee-for-service system into an accountable type system, and this offloads risk from the payer to the provider, and it becomes a risk-sharing type of a system. And what this fundamentally creates is an incentivized to focus beyond just the inpatient stay. So to focus on preoperatively making sure that we're bringing patients to the hospital in an optimized state. And I'll show you the protocol I've got for that, and I hope some of those will be worthwhile take-home points. But also what happens after we leave the hospital. So many of you are familiar, we wrote about readmissions, and our readmission rate for patients who went to a SNF was 11-fold higher than patients who went home. So really trying to direct patients towards home, trying to make sure patients are optimized preoperatively to be able to discharge. Our length of stay was significantly shorter for patients who went home than it was for patients who went to a nursing center and a lot, or that went to a rehab. And a lot of times that has to do with waiting for a rehab stay. And that's where we've got a lot of ability to affect our 90-day costs. And I'll just share with you our experience. What's included in the bundle is everything from medications to lab services to physical therapy. And importantly, a big part of the bundle ends up being the outpatient care. And a big part of the risk is when we readmit patients. A big part of the risk is also having patients go to nursing facilities or rehab facilities for 2 weeks or more. And that's where there can be a lot of, I don't want to get too much into the detail of these numbers, but looking at 90 days, the biggest variable is what happens after the patient actually leaves the hospital. And that's where when we looked at our bundles, the 4 bundles many of you know include basically everything except a fusion is one bundle, cervical fusions, and it's such a broad category. We're looking at the variance of this, and it's tremendous variability, but cervical fusion is an anterior and posterior compared to a single level posterior, single level ACDF, thoracolumbar spine fusions. We found that in every one of these categories, our present costs are more than are allotted by the bundle. and where we've got the best opportunity to reduce present costs is by changing our surgical strategies and by changing what happens after patients leave the hospital. I'm going to share with you some of the numbers we came up with looking at our costs. And just looking at a lumbar discectomy, our direct costs range from under $4,000 to over $8,000 for discectomies. A lot of this had to do with disposables and length of stay. For single-level fusion, again, this is a paper that Jens's group is evaluating right now in a global spine journal, but single-level fusion direct costs from less than $10,000 to over $70,000 for some patients with complications or prolonged length of stay. What were the drivers? Well, to some extent, the implant costs, use of biologics, length of stay, and the surgical strategy, front and back surgery versus posterior-only surgery. When we looked at deformity, these were multi-level fusions. Overall, a lot of variability. Our range was up to $140,000 of direct costs. As you'd expect, the circumferential fusions were the highest, and the long fusions to the upper thoracic spine were higher than the fusions stopping at the thoracolumbar spine. So being transparent about these direct costs, we were able to look at a number of things. One of the things was interesting. Our overall revision rate at an average of about 3-year follow-up, our overall revision rate was 34%, which is something that's got to be better. It turned out that men were less likely to have revision surgery than women. BMI was highly associated with revision surgery. So patients with a BMI more than 35 were actually 7-fold more likely to have a reoperation than patients with a normal BMI. Some of the other numbers that we looked at, well, what's the correlation between what we spend and what the outcome is? And as you'd imagine, an R value of 0.03 suggested, or actually the R value I think here was 0.6. I'm sorry, 0.06. But a very, very, very low correlation between what we spent and what the outcome was. So how then do we create a multidisciplinary team, and how do we create a system that actually provides care that's more efficiently? And fundamentally, what we're doing now is we're working with our non-operative colleagues. We're trying to integrate a physical therapy first type of a program where the unspecified referral goes directly to physical therapy, works with physical therapy and pain management to try and create an integrated non-operative service. I want to talk specifically about how do we create better efficiency in our costs for some of these multi-level fusions. Well, one of the areas is by preoperatively optimizing these patients, by intraoperatively creating strategies that are consistent, and by postoperatively being accountable for what happens. And I'll show you how, to some extent, the preoperative defines the postoperative. So what are we doing preoperatively? Well, number one, looking at risk, looking at patient expectations, trying to empower shared decision-making. We're medically optimizing patients before surgery. And I'll focus on exactly what I do there. So this is from my electronic health record here. So this is me logged in here to my electronic health record. And I've got a little dot phrase. It's dot pre-op op. And when I type that in, for every single patient, this comes up. And it creates a system that, to some extent, gives me some quality assurance. Is number one, the hemoglobin A1C. Is I don't do any elective spine surgery with somebody who's got a hemoglobin A1C more than 7.5. Bone health. I won't do an elective spine surgery on somebody who's got a DEXA score less than minus 2.5 unless they've already been on teriparatide or unless they've already been treated. BMI. I won't do an elective spine surgery with a BMI more than 35. And people laugh about that, but it's absolutely true. I wouldn't operate on me. I'd say you need to be optimized before I'd operate on you electively. Now, a lot of what I do, obviously not elective surgery. Serum albumin, I won't do an elective spine surgery and serum albumin less than 3.5. Assess the infection risk in all these patients. Won't do elective spine surgery on a smoker. Here's an interesting one, pain medications. We showed that patients were taking more than 50 milligram of morphine equivalent per day. Those patients had a significantly longer length of stay in the hospital. So patients more than 50 milligrams of morphine per day get a pain management consult before they're scheduled for surgery with the goal of trying to get them down to less than 50 milligrams of morphine and the notion we can control their pain better and get them out of hospital faster with that kind of optimization. Quantifying their coagulation status, looking at systemic disease, and this is a really big part of it, is their social support. There's also a measure in here for frailty. We do a Edmonton frailty score. But social support, the social support is a metric of essentially what's the patient's rehab potential, what's their likelihood of being discharged to home. And a big part of that is who do they have to help them at home and how well is their home set up to go home. And we'll optimize that to make sure that we don't bring somebody into the hospital and find out when we're trying to discharge them, you know what, they live in a 3-story walk-up, there's no elevator, and they live alone. Or even more so, we find out that they're homeless after surgery. Right? And that's something that if you don't look into it, you don't find out until you're surprised. So preoperatively, everybody gets this checklist, and I won't do an elective spine surgery unless this is optimized. And that's led directly to reduced lengths of stays, reduced readmissions, and essentially better patient satisfaction as well. Now, you know, on any given day, yeah, you're going to see a lot of patients who don't meet these criteria because there's a lot of tumor surgery, a lot of patients who are myelopathic, a lot of patients who have rapid progression, deformity, trauma. So it doesn't apply for everybody. But when it comes to the elective patient, where there might be a 6-month wait anyway, we're going to spend a lot of time incentivizing this kind of optimization. And I've actually got the hospital to buy into this such that I've got resources for a nurse navigator who makes sure that when that patient comes back for surgery, these are all optimized. And yeah, sometimes we are operating on patients who are osteoporotic, but we've actually done all we can to optimize their bone density, including in most cases, get them on a teriparatide for at least 6 months before surgery. Well, what about being able preoperatively to predict outcomes, to predict complications, junctional kyphosis? We published on what are the predictors of reoperations and readmissions. And again, that was where, to a large extent, renal function was a big predictor there, kidney function was a big predictor there, BMI was a big predictor there, length of stay, medications, and home situation was a predictor there. We could predict reliably with regard to the weather. We could predict reliably what the weather's going to be here tomorrow because we've got 1 million data points. We've got barometric pressure, we've got oceanographic information, we've got satellite information. The difficulty in predicting with regard to spine surgery is we just don't have that many data points, and there's a lot of variability. So in terms of predictive modeling, I think the work that you all have contributed here is terrific. And I suggested that we did a lot of work in predicting complications, but what about predicting outcomes? And I'm not going to walk you through this work because many of you here contributed to this, but this notion of empowering and informed choice, both by physicians and patients, by suggesting, hey, what's the likelihood that you're going to do well? And recognizing there are specific variables that influence the likelihood of you doing well. A lot of those variables had to do with your preoperative health status. A lot of those variables had to do with your preoperative disability. But recognizing these variables, and I use these interactive modules. I haven't had much experience with this one yet, to be honest, but I use the sport calculator. Does anybody use the sport calculator for patients with disc herniation or spinal stenosis? It's a really good one. It's available online. It was sponsored by Consumer Reports. You can go online and basically put in demographic or put in some patient-specific information. It just takes about 2 minutes. And then with the patient, you say, hey, here's what's likely to happen over 8 years if you're treated non-operatively, and here's what happened to patients like you who are treated operatively. And it gives us the ability to really quantify expectations. I've also used, the Spine Sage calculator, which is a pretty interesting one to look at complications, right? When you say your likelihood of a dural tear, your likelihood of a readmission is in that case, that calculator predicts some pretty high likelihoods of bad outcomes. And it really brings into a quantifiable notion what's likely to happen. And I think these are terrifically powerful tools for our preoperative discussion. What about intraoperatively? Well, some of the things that we do a lot of intraoperatively, having protocols with regard to blood management, having protocols with regard to our surgical techniques, our preoperative plan. A lot of times we at UCSF use 2 attendings. I know you do some of that here as well. And trying to reduce complications, trying to make sure that we've got appropriate protocols to minimize blood loss and reduce complications. And then postoperatively, again, having some standardized pathways that have to do with early mobilization, early feeding, appropriate prophylaxis. Delirium was one of our major risk factors for infection, trying to prevent delirium. Trying to get patients to home rather than getting patients to a rehab or to a SNF where they're more likely to be readmitted from. And that really requires a lot of preoperative preparation. So what I want to wrap up here with is Francis Well Peabody was a physician back in Boston in the mid 19th century, and he wrote this classic book about the art of medical care and caring. He said that one of the essential qualities of a clinician's interest in humanity for the secret of care of the patient is actually caring for the patient. And I bring this quote up at the end here because we talked a lot about metrics and process variables and quality measures, and so often those metrics for quality and those metrics for process measures are dissociated from the patient. And I think staying patient-centered in our metrics is really critical. And that's why, again, I thought that article in JAMA, we're not just looking at complications and reoperations in a predictive model, but actually looking at outcomes, looking at the patient's self-assessment of their experience. Being patient-centered is fundamental to what we're doing. So my conclusions, and I think what I showed is that spinal disorders, the disorders that we take care of as physicians who manage patients with spine problems, that represents a significant burden. And it's an important healthcare priority for our healthcare economy. Optimizing how we manage spinal disorders requires interdisciplinary collaboration, and we can't be myopic about this. We can't see every patient as a nail and all we've got is a hammer. We've got to develop care plans that actually span the continuum of care. And I think a lot of healthcare reform initiatives are forcing us to look at that continuum. They're forcing us to be economically viable, to be efficient in terms of our reimbursement as a hospital system, to preoperatively bring patients to surgery under appropriate circumstances and well optimized, to treat people with standardized protocols in the hospital, and to make sure we treat them efficiently postoperatively and avoid reoperations, avoid readmissions. And the opportunity to improve how we take care of spine patients through integration of services with multiple disciplines, I think this is where integrating our services is what reduces our variability, it improves our efficacy, and ultimately it provides compelling evidence to our payers who are looking at for accountability, not only over a 90-day episode, but for our patients, where we're accountable over our lifetime. I think that we're transforming our healthcare system to an evidence-based strategy that provides optimal care, getting everybody involved and creating a better consensus in how we provide care. So that's what I wanted to share with you and some of the work we're doing, again, at UCSF towards providing optimal care. I think together we can learn a lot from each other. So maybe there's some chance for discussion. Yes. Thanks.